Hi everyone, the topic today is pneumonia. Someone walks to a doctor, he or she tells the doctor, the lungs are sick. My lungs are sick. Yes, that is true. Okay, let's find out more. There are different types of pneumonia. In the course of this presentation, I'll go over the following: community-acquired pneumonia. I'll go over that in details. Nosocomial or hospital-acquired pneumonia, that is to those who acquired pneumonia while being admitted in the hospital. Aspiration pneumonitis, I will talk in details about that. And of course, aspiration pneumonia. Apostatic pneumonia to those who are bedridden or who are not moving around. Pneumocystic jirovecii pneumonia, otherwise known as pneumonia in HIV or pneumocystic carrier pneumonia. I'll talk in details later. Pneumonia in pregnancy. Pregnant women could come down with any kind of trouble, but I will address pneumonia very soon. Pneumonia in children doesn't limit itself to a particular age group. Everybody is susceptible. Viral pneumonia. Legionella pneumonia as a typical form, Klebsiella pneumonia, Mycoplasma pneumonia is also atypical, Kleb is also atypical, and Chlamydia pneumonia. I'll talk about them separately in the course of presentation, but today I'm going to talk about community-acquired pneumonia alone. So let's go. Okay, pneumonia. Pneumonia could be bronchopneumonia. In that case, the primary involvement would be that of the bronchi and the surrounding alveoli. It's very common in young children because of the immunity is not yet strong, and elderly because immunity is going down. And of course, in immunocompromised people. Lobar pneumonia, on the other hand, affects only a single lobe. For example, it could be right middle lobe pneumonia. Now, community-acquired pneumonia. Community-acquired pneumonia in adults is a worldwide problem. It causes morbidity and mortality in many. The causative agent was acquired in the community, not in the hospital. That is a major difference here. It is acquired in the community, not in the hospital. That's why we call it community-acquired pneumonia. But because I'm limiting this to the situation in adults, I've called it community-acquired pneumonia in adults. In children, I'm going to talk about that later. The pathogenesis here will be that the lung parenchyma has been infected by either bacteria or a virus. You get the microbes from droplets. Droplets are minute drop of liquid. You can also get it from aerosol inhalation, from nostrils to pharynx, then to the lungs and the alveoli, depending on the immune status. If your immune status is impaired, then you come down with the infection. The immune factors and the ability of the pathogens to establish themselves will lead to the inflammation. Remember the slogan. I'm still talking about the pathogenesis of pneumonia. Remember the slogan, and don't allow battle in your territory. Why? If you don't lose men, you're going to lose properties. The same thing will take place inside your lungs because the parenchyma will be damaged, and that is called pneumonia. Smoking, viral infections can trigger the excessive growth of normal alveolar flora. In other words, in every human being, there are normal flora in our respiratory tract, just as we find on the skin and other parts of the body. But smoking and viral infections, of course, immunity can trigger the growth of those normal flora. And anaerobic organisms, Prevotella and Venonella, are very difficult to culture. You might have had experiences when you or somebody close to you, or your neighbor, or your friend, your family member must have had pneumonia, and they would do culture, sensitivity, everything, and they will tell the person we can't find any organism. That is the reason why you may be told there is no organism found on microscopic culture and sensitivity tests in 70% of hospitalized patients and greater than 90% of outpatients. Why? Prevotella and Venonella are very difficult to culture. It's not that they're not there, but they are difficult to culture. The system will respond to your situation to prevent spreading into the blood, but that leads to tissue injury. Now, when, like I said, don't allow value in your territory. If you don't lose men, you're going to lose property. So when there is war between your immune system and the pathogens, then there will be injury on the battlefield there. Then when they are able to get into the bloodstream, they cause sepsis, and within the lungs, they cause respiratory distress, and still affecting the other parts of the body, they cause multiple organ failure. So pneumonia is a very serious issue. The culprits there are Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis. You must have heard all those three names when I discussed about otitis media. You must have heard all those three names: Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis. Staphylococcus aureus could be methicillin-sensitive Staphylococcus aureus or methicillin-resistant Staphylococcus aureus. Those are not just semantics. The names given here will determine the type of antibiotics you are going to use. Could be anaerobes, could be pseudomonas, mostly found in cystic fibrosis. I have made a detailed presentation on cystic fibrosis, kindly check out. And pseudomonas is also common among chronic obstructive pulmonary disease affected people and immune suppressed states. Could be group A streptococcus as well. Community-acquired pneumonia could be as a result of atypical bacteria, in which case Legionella, Mycoplasma, and Chlamydia will be implicated. So when you see the write-up and the doctor has written down Legionella pneumonia, you should know that you are dealing with atypical bacteria. And could be as a result of viral infection as well, like annual flu, influenza, respiratory syncytial virus, parainfluenza, rhinoviruses, or adenoviruses. What are the risk factors here? Old age. Like I said, bronchopneumonia is common among elderly and very young people. So the older you become, the weaker your immunity is likely going to be. Associated morbidity like chronic obstructive pulmonary disease, asthma, congestive cardiac failure, stroke, diabetes mellitus, malnutrition, and decreased immunity. When you have all these problems, it's likely that your immunity won't be strong enough, and already with the COPD, asthma, and the rest like that, your lung is already having trouble. So there's hypersecretion and everything like that that could form as needles for bacteria to multiplicate very rapidly. And also with the decreased immunity, you are unable to fight these microbes, and you're likely going to come down with community-acquired pneumonia. Overcrowding, like group homes, shelters, and prisons, like I've stated that it could be acquired through inhalation and droplets and so on and so forth. So when somebody is having it and is living with different people in a crowded environment, then it's going to be spreading very fast. Altered consciousness. The people that have altered consciousness could have many different types of pneumonia. They can aspirate, and so on and so forth. So that will be a big factor. Aspiration secondary to alcohol, seizure disorder, anesthesia, or stroke. So when there's paralysis anywhere and the cough reflex is cut off or anything like that, then the microbes could be inhaled from the gastrointestinal tract down into the trachea and lungs and propagate the trouble. Toxins like gasoline and paints could serve as chemical pneumonitis, upon which there could be bacteria superimposed secondary infection. Smoking, I cannot overemphasize the need for you to cut down smoking or quit totally. Alcohol, for the same reason of aspiration, opioid dysphagia leading to aspiration, impaired lung defense, e.g. poor coughing reflex, poor gag reflex, illness, or street drugs. The clinical features could be some of this because it's not likely you're going to find all these in one patient before you make the diagnosis. So there could be cough, and you ask about the pattern of the cough, with or without sputum. And if it is without sputum, is it blood stain, hemoptysis, or not? Although pneumonia is not the only cause of hemoptysis, we'll get to differential diagnosis of pneumonia very soon, because it could be tuberculosis, lung CA, and so on and so forth. There will be possibility of chest pain, and in that case, to be pleuritic. When the patient inhales, they feel the pain the more. But chest pain could not be limited to pneumonia as well, because it might be even cardiac in origin. So we deal with that in differential diagnosis. Dyspnea, fever. Of course, fever is not pathognomonic of pneumonia alone. There could be chills, increased erythrocyte segmentation rate, C-reactive protein. When you're thinking of autoimmune condition going on here, there could be hypotension if there is associated sepsis and decreased level of consciousness, thrombocytopenia leading to bleeding, increased heart rate, and of course apausia. In elderly and immunocompromised people, please note the symptoms might be decreased. So you may not have the classical presentation of all the clinical features that I've just mentioned in elderly and immunocompromised. So when we see elderly men and women, we take extra care to make sure pneumonia or urinary tract infection is ruled out, because most times they may not even have fever. Yeah, we don't judge elderly men and women to be pneumonia free or urinary tract infection free until we have carried out detailed investigation with history. Because the only thing they could present with most of the time would be decreased level of consciousness. They just feel confused, and that might be all. You take the temperature, the good nurses, they take the temperature, and it's just within the normal range. And the symptoms are not that classical. And even when electrolytes and other factors are taken, may not give you the clue, and then even complete blood count might not yield leukocytosis in elderly. So it's we need high level of index of suspicion to arrive at diagnosis of pneumonia in elderly and immunocompromised people, because what the process would take to release every gathering things that will lead to fever is already down and down. Like I've said briefly, increased alter level of consciousness might be the main clue in elderly people. By the time we deal with urinary tract infection in elderly, we'll come across this type of situation also. And when physical examination is done with auscultation, find crackles, bronchopneumonia, ergophony, and whispering pectoral liquid. And of course, on percussion, there'll be increased dullness, giving us a sign that there's consolidation going on. How do we make the diagnosis? Particularly, I've just mentioned in elderly, where you may not find the clinical signs, not just like that. No fever, no leukocytosis. The symptoms are not just many, but my grandpa is confused. My grandma is a bit confused right now. So how do you make the diagnosis? Do chest X-ray. Chest X-ray may not reveal pulmonary infiltrates. Why? If there's immunocompromised status here, and if this patient is severely dehydrated, we may not see the pulmonary infiltrate with patchy, opacity. We may not. And when we do PA and lateral views, we can see lobar infiltrates in lobar pneumonia, bronchopneumonia in immunocompromised. Chest X-ray can be completely negative in immunocompromised because of what I've said. The immunity is not there enough to fight the organism and release all those parameters that will lead to the features we're going to find. If we are confused, no patchy opacity, nothing on the X-ray, and you are still suspecting pneumonia in my grandpa, do CT. Do CT in elderly if you are still suspicious, and the chest X-ray is equivocal, so it's not definitive. If chest X-ray is not definitive, tell my grandpa to do CT. I'll take him there. Bronchoscopy with washing. For what? For refractory case, severely ill people, and immunocompromised. And of course, pulse oximetry. Sputum for gram staining, microscopy, culture, and sensitivity, but I've told you it's not in all cases that you're going to get something out of it. You can come back and they tell you it's negative. That doesn't mean you're afraid. You can tap pleural fluid for microscopy and culture and sensitivity. Take blood sample for blood culture. Viral serology, if you're suspecting viral etiology here, like if many people are already infected or is around the flu season. Of course, having ignorant flu season doesn't mean it is only viral. It could be bacteria superimposed on the virus or secondary bacterial infection, particularly Staphylococcus aureus. Complete blood count and differentials. Blood, urea, nitrogen, creatinine, and electrolytes. Let us say them. Arterial blood gases. We want to know how the lungs are doing and what is happening with metabolic system going on here. And of course, we have to rule out myocardial infarction in anyone that is having chest pain. So it doesn't going to cost too much to do cardiac enzymes. And even if you're kind enough and you have the resources, do EKG for my grandpa. Why? There's possibility of silent ischemia in my grandpa or grandma, and I have made a separate presentation on that as well. Kindly check it out. Heart attack 1, heart attack 2, up to heart attack 6. You will come across particularly heart attack 2. I have made detailed presentation on silent ischemia and silent myocardial infarction. So rule it out. When my grandpa comes to you and tells you he's having pain in the chest, and of course liver function test. Treatment of pneumonia. Outpatient treatment if the person is healthy, normal vital signs, and pneumonia is mild by your own clinical judgment. But if you think the individual has not met this parameter, then consider hospital admission. But before you do that, you do what we call COP65 score. To the medical student and nursing student, COP65 score is all about confusion. When it is altered, level of consciousness, that is 1. We measured urea and blood urea nitrogen, and when it's greater than 7 millimoles per liter, or blood urea nitrogen is greater than 20 milligrams per dl, that's 1. Respiratory rates greater than 30 cycles per minute is 1. Blood pressure less than 90/60 is 1. It means you are going to have hypotension here. And of course, my grandpa is greater than 65 years old, that is 1. So when you add all these scores together, if you have total score of 0 to 1, then you don't need to admit, because the mortality in them is less than 5%. Treat with good antibiotics. If it is 2 to 3, please admit. Why? The mortality will increase to as high as 5 to 15%. If you could get 4 to 5, please intensive care unit immediately. Why? The mortality will be as high as 15 to 30%. You can choose from macrolides like azithromycin, clarithromycin, or erythromycin. Fluoroquinolones like levofloxacin, moxifloxacin, or gemcitabine could be used. Bictal like ceftriaxone, cefpotaxime, and clavulin with augmentin or unacin could also be used. So you have a lot to choose from. While in hospital, of course, you're going to admit and you check the airway for foreign body, secretions, you suck as it is appropriate. Breathing was happening to the chest region. You look for any deformity, any scar, moving with respiration, the pattern of breathing, is it respiratory distress, flaring of other nasal, accessory muscle being used, calls for donuts, auscultate, for crackles, air entry, and so on and so forth. Circulatory system for vital signs, the blood pressure, the heart rate, dehydrated or not, fluid in and out, and of course you hook up your IV line for maintenance fluid here. Arterial blood gases, and we correct any anomalies there. We give oxygen when O2 sat is revealing, and we treat appropriately. Please, you can and you may not, depends on the protocol at the center. You can use bronchodilators, like salbutamol. Chest tube and drainage, if you could pick pleural effusion on CT or chest X-ray or on auscultation and you confirm with radiological imaging. Intravenous antibiotics like tazocine and ceftriaxone. Tazocine is a combination of piperacillin and tazobactam. What are the differential diagnoses here? It could be congestive cardiac failure. We might be dealing with pulmonary embolism. It is possible this is pulmonary hemorrhage leading to hemoptysis. How about lung collapse? This could be lung carcinoma. Could be aspiration of chemical into the lungs called pneumonitis. This might be autoimmune, and sarcoidosis is implicated here. Asbestosis from occupational exposure, and bronchitis in COPD people. Could be long-standing asthma or tuberculosis. So we just have to walk around and rule out all these possible causes and even more until you are able to arrive at the exact diagnosis. What are the possible complications here? Lung abscess, adult respiratory distress syndrome, empyema thoracis, pleural effusion, pleuritis, sepsis, DIC, and hemorrhage. In conclusion, watch out for more pieces of info on other types of pneumonia. Like I promised, I'm going to fulfill that. I'm going to work on the rest, nosocomial, atypical, and pregnancy, and so on and so forth. But know this, and that is my major concern. Let's do anything to prevent this, because prevention is better than cure. Thanks for listening to my presentation. Kindly subscribe to my channel so that I could be getting these presentations as soon as they are published. Thank you.